Because adversity is often the breeding ground for development, dive into neurointerventional stories, the uncensored interviews. Our guests, all leaders in the field of neurointervention, share the difficulties they face, the complications they have had to manage, and speak without filters on little discussed, sometimes controversial, or simply taboo subjects. Hello everyone, my name is Nanthiya Sujijantarat, and today I am pleased to welcome Dr. Tommy Andersson with us today. Dr. Andersson, how are you?
I'm very well, thank you, and thanks for the invitation. I'm delighted to be here.
Dr. Andersson, can you briefly introduce yourself in a few words and your background?
My background is originally from neurosurgery, and then I got an offer to train in neurointervention, starting out in Toronto, actually, and then, of course, also in Stockholm at LINNC. And after that, I've been working in Karolinska University Hospital ever since, but I also did 1 year full-time in Belgium, in a city called Kortrijk, with AZ Groningen. And then I have commuted, working 1 week a month, 2 weeks a month in Belgium, in that hospital, but all the time also in Stockholm. But now I'm full-time in Stockholm.
You're a citizen of the world.
Well, yeah, maybe. I was very happy to be there. The training was really good, and especially the atmosphere and the environment. Just by being there, you learned a lot. So I'm very appreciative for having the chance to stay in Toronto with Professor Tebrug and the team there. Nice city as well.
Very competitive environment as well.
Yeah. And especially at the time, the unique part of Toronto, I think, was that they had the collaboration between neurosurgery and neurointervention. And that was, at that time, a little bit unique. And coming from neurosurgery, to me, it was really beneficiary because I could be a neurosurgical fellow but still learn doing neurointervention.
Is there any part of general neurosurgery that's still in your practice today? Or?
No. In the beginning, I did both. I did also open neurosurgery. But after a while, I realized I have to focus because it became a little bit, I was split. I mean, I didn't know really what to do. So in the end, I said, okay, let's focus on neurointervention and try to build it. At that time, together with my partner, Michael Söderman. So we kind of built the practice of neurointervention in Stockholm together.
What was the landscape like at the time? Was there anyone doing neurointervention in Stockholm?
Yes, there was. Michael had done it before, and as well as another one. The problem was that they came from neuroradiology,
right,
and they had both been trained actually in France. But because at the time, this was more like a turf war than it is today. So in the end, there was a meltdown, you could say. So the guys in Stockholm said, what are we going to do? How are we going to solve this? Well, maybe if we recruit a neurosurgeon, they can't fight each other, can they? So let's recruit a neurosurgeon. And I had done a rotation in neuroradiology because I wanted to learn to read MRs and stuff like that. So they asked me, maybe you want to learn how to do neurointervention. I was interested in vascular neurosurgery, so it made a lot of sense. But why should I do that? I mean, what's in it for me?
Yeah.
And they said, well, you can go to Toronto because my boss at the time in Stockholm was a good friend of Professor Tebrug's. So they said, you can spend 2 years in Toronto, we'll pay everything. You have your salary, we pay your trips, go to conferences, buy books, it's fine. The only thing we want you to do, come back after 2 years, you start the practice here. I said, wow, this is an offer I will never get again.
Yeah.
So I'll take it.
Yeah.
So coming back, I realized this will be difficult to do on my own. And then Michael was still there, but not practicing so much. So I managed to convince him to do it together with me. So the two of us, you could say, we built it together. And the way we did it, which I must say I think was kind of smart, was that I said to him, okay, so I'm coming from the clinical side. Let me focus on that. I'll take care of the clinical part. You come from the radiology side. You know all about radiology part. You focus on that. And then we focus on our strength and we do it together. And that worked out quite well. And in the end, it was a mix, and I learned from him, and he learned from me, and so that was basically the story.
I had an interview just before you, and actually this was someone on on Twitter that suggested this question, a young neurologist, aspiring neurointerventionalist, who asked, how could we capitalize on the 3 different specialties, knowing that you're probably going to get trained as a path to one. And we realize that there's so much cross-training that occurs within our field, either from, someone who graduated from neurosurgery residency, getting trained by a radiologist, trained person, or someone who has partner like you, who's from another field. Yeah. So that's sort of where the field is moving to.
To me, I think it's in Portugal when they start together with neuroscience, you could say, and then much later they split into neuroradiology, neurology, neurosurgery. To me, that makes a lot of sense. I think, obviously, we should work together. And I never really understood this kind of borders in between. I mean, we all like to treat our patients in the best of ways, and we have a little bit different knowledge in the background. So why don't we benefit from that and work together and learn from each other? To me, it's obvious.
No-brainer.
No-brainer. Yeah.
What is the landscape like right now in Sweden?
Right now, it's quite okay, I would say. It wasn't okay 25 years ago when I did this. Then it was still a bit of a struggle. So when I came back, still being a neurosurgeon, and was supposed to start neurointervention together with a neuroradiologist, there was some of the neuroradiologists who were a bit reluctant to accept that. So in the beginning, it was like people I thought were my friends all of a sudden didn't say hello when they met me in the corridor or something. With time, this changed, and I would say now the problem is small, or no problem, you could say. I think now we train neurosurgeons, we have trained neurologists, we have no problem with doing that. We benefit from everyone, because if they have different backgrounds, we learn from them. So I think it's still, now this is not a big problem anymore. What is a little bit of a big problem is that who's responsible for the patient? And that, at least in our society, it's still, if you're a clinician, if you have an aneurysm patient, belongs to neurosurgery. If it's a stroke patient, belongs to neurology. But it's treated by perhaps a neuroradiologist. Right. So who is then responsible for the patient? Right. Obviously, you're responsible for the treatment that you do, but then afterwards, who should order the double antiplatelet? Who should do the follow-up? And I think that still is a little bit of a not completely solved.
Yeah. So I'm going to shift gear a little bit, and we'll just start by the question that we ask everybody, which is that what would you say are the biggest professional difficulties that you've had to face in your career?
Well, I would say that in the beginning it was this kind of thing that we just discussed, that to be accepted, to do the neurointervention, and to be accepted by everyone. In the beginning it was a bit of a struggle. I had a good sort of starting point because I was a neurosurgeon. So, for instance, when we started to have rounds together, some of the neurosurgeons at the time said, this could easily be operated, so why should you treat it? And I said, no, it cannot be easily operated. I know, for I've done it, and it's not an easy case. So I could meet that. But in the beginning, that was a little bit of a struggle to sort of who should do it, and for them to accept that neurointervention was actually something that was developing quite rapidly. And as well as the neuroradiologist accepting the neurosurgeon sort of leading the neurointervention, that was also a bit of a struggle. So in the beginning it was like a little bit tough to sort of, in a diplomatic way, work it out. But I think with time and the fact that I work with Michael, they saw that this practice was actually becoming better and better and well recognized. In the end, it sort of eased out. So now the problem is much less, I would say. But that was a bit of a problem in the beginning, yeah. So we'll talk about, similarly, have you had to overcome personal difficulties in the pursuit of your career? Yes, of course, like everybody else. I mean, in the beginning, when I came from neurosurgery, so I've been on call for neurosurgery, primary on call, and I was, like everybody else, working a lot. And then in the beginning, we were on call also for neurointervention. I thought this was vacation. It was nothing. I mean, we didn't do much. Then came stroke. And we started very early on with stroke. We started our first cases in 2004.
Oh, wow.
And with the support of neurology, with that, the workload increased a lot. So in the beginning, we were quite few. So we had to be on call a lot. And even if we didn't work every night, the problem was that we still had to stay home within 30 minutes. So socially, it was a bit handicapping. You couldn't go with your family for the weekend. You had to be home, ready to go, and so on. It was, especially when the kids were small at the time, it was a strain for the family, I would say. And on top of that, traveling, going to conferences, trying to learn, trying to be better. Yeah, it was tough for a while.
Yeah, continuing medical education is certainly like a very unique part of our field too, because there's so much that evolves so rapidly compared to other fields. So conferences like this are vital. So we'll focus a little bit. I think you have a unique perspective coming from Sweden. So I wanted to talk a little bit about patient care in your country, if you wouldn't mind. So obviously there's a great variety of practice pattern depending on the country. And in your opinion, in what area should your country or your region focus on in the impact of health policy and regulation in driving that?
It's a difficult question. I think, healthcare in Sweden is a socialized medicine. We're all on salary. We're salary-based, which has pros and cons. Pros, of course, that we hopefully don't do things that shouldn't be done. On the other side, there's no economic incentive to do something, which could be good, could be bad. I think generally, population-wise, the population trust the doctors a lot. And if you ask the population, where do you want your tax money to be spent? Almost everyone says healthcare, no doubt. So we do have a lot of support from people. I think if you really have a bad disease like an aneurysm or an AVM or something like that, you're basically taken well care of. What doesn't work in my mind that well is the primary care. Like, let's say you want to go to a family practitioner, there's a little bit of a problem. To me, that part doesn't work that well. But if you're really sick, it works quite fine. So I think we need to be better on the primary care, and everybody kind of agrees with that. From our perspective, I mean, this is good and bad, but the fact that we don't have an economic incentive is good because we don't do unnecessary stuff. On the other hand, the tendency could be to wait until tomorrow, do it next day, and so on. So a little bit of a mix could be good sometimes. But I think we have good support in neuroradiology. In Stockholm, for instance, we have 3 angio machines dedicated for neuro. We have several MRs, 3 Tesla, now a 7 Tesla. We have 1.5s, we have a lot of CT. So we have a good setup, actually, to do a good job. And I think, basically, we do a good job most of the time.
What's the access like for stroke care, for thrombectomy? Do most of the population have access to centers?
The problem in Sweden, of course, it's a large country with a sparse population in the north. Right. So it depends a lot on where you live. But there are 7 centers doing endovascular stroke care now, and they are all well developed. The problem is that if you choose to live in the north, to travel, the time to the nearest center it's a long time. So there is a problem because of geography, because of how the country looks like. But they're trying to fix it. But something like remote stroke treatment in this setting could actually be something that pays off, I would say. And also maybe starting centers that do not do everything in neurointervention, but more focusing on stroke and doing that. I used to say that a suboptimal thrombectomy is better than no thrombectomy, because the worst thing is probably to do nothing. And if you still do it and you can treat the majority of patients, it's better. And even if you don't do the super advanced treatment, maybe it doesn't matter so much.
What's the state of interventional research in your country?
I think it's okay. We're not the most active country, I would say, but we participate in big studies, and we try to also do our own studies, of course. But it's very much up to personal. I mean, if you want to devote the time for it, it's not that common that you have in your contract, so to speak, that you're allowed to have certain time set aside for doing that kind of research, and I think that could be better. In a university hospital, they like everyone to have a PhD. So that's not the prerequisite, but it's sort of, they really want you to do that.
Yeah.
So most of us have PhD as well.
Wow.
I think it's good in a way, because I think if you have a basic science background, you know how to get knowledge, you know how to find knowledge, and you know how to implement knowledge.
Right.
Because that was part of your training. So I think recruiting people who have that background is always good, because they are sort of used to learn, they're used to find knowledge and apply knowledge. So I think, to me, it's not a bad thing.
In your personal practice, how do you integrate adopting new things and using new things into the framework of what your practice allows and the framework that the country has created for you?
I personally think that this development of new devices, of new things, is good. I mean, that's what's driving our field forward. So I really think that's something necessary, and that has been good in the past. On the other hand, I think we have to be careful also, because we're treating patients. And we really, if we use a new device, it should be because we really think that's the best thing we can offer for this particular patient. It shouldn't be because I like to do this so I can show it in the next conference that my first 5 cases, look, I've done it. I think we should do it because we think it will be good for the patients. But if we do it like that, I think it's good that we have this sort of collaboration with industry. And it should be done in a serious and a controlled way. Me and Michael, we've been helping several companies to develop thrombectomy retrievers. I mean, we helped Concentric Medical, that finally became the Trevo. We did lots of work with Neuravi to develop the EmboTrap. I think it worked out quite well for both parts and for the benefit of the patients. Yeah. So I think it's good, but it has to be done for the right purposes.
Right. So are you guys a stent retriever first center?
Yes, we are, or combined now, I would say. But I think personally, to me, this debate, what to do, it's not interesting anymore.
Yeah.
To me, it's like you should be able to do everything. You should have everything on the shelf. Every possibility should be there.
Yeah.
And you should try to do what you think is best for that patient.
Right.
And that could be aspiration. That could be retriever. That could be double retriever. That could be combination. You shouldn't say, I always do it like this. No, you should do what you think is best for this particular patient and optimize what we do. We can remove 80%, 85%, 90% of the clots of the thrombi, I wouldn't say easily, but straightforward. But some of the patients still do not do well.
Right.
Why? Well, because we clean the vessel, but we do something bad at the same time. We lose parts, we do this. So now it's more interesting to see, how can we be better? We have a few clots that we have problems with. Yes, we focus on those. We find new ways to those. But the majority, we don't have a problem to remove them. But we should do it in a way that the patients do even better than they do today. I think that's a more interesting discussion for me.
So at the end of the podcast, we ask the same 4 questions to every interviewee. Okay. So the first one is that if we had gone back 10 to 15 years into your past, was there anything that you would have done differently?
I thought about that, and to be honest, I'm not sure. I think, like I said before, we started to do thrombectomies in 2004 and 5, and very rapidly we were convinced that this was good. And the neurologist was also convinced, because they saw the patients that we did and the results were good. Still, it took another 10 years before it was accepted, and all of a sudden it went from, this is experimental, you shouldn't do it, to we should do it for everyone. Because the studies. Sometimes I've been thinking, all the patients during those 10 years that were not treated because there was no evidence. And I was feeling, of course we need evidence, we should go for evidence-based medicine, but this was so obvious to me that this was something good. So the fact that it took 10 years to implement it, that's, I think, was not so good. I'm happy that in the end it turned and now we see the opposite. That's fine, but it took a little bit too long, I think.
Yeah. And if we fast forward 15 or 20 years from now, where do you think our field would be?
I think now we see technological development maybe faster than even before. We see things that can be done. For instance, I'm amazed when I see now how the treatment of an AVM is done. When I started to do it in the beginning of 2099, something like that, it was by random. You throw a catheter in and you inject some glue and nobody knows what will happen. Okay. And there was lots of ideas that you stabilize this. And I think it was just crap.
We just have no clue at the time. Yeah.
And now I see the workup that's done before you even start the treatment. You have these 3D, the 6D, the 4D, you do this, you do that, and you plan it, and you have a good plan from the start. And the plan is to eradicate, to get rid of it. And you do it in a much more controlled and much more worked up way, and I think that's really great. And that is what we will see, I think, more and more. And we will have more training beforehand, we will be able to do it safer, and I can see that coming more and more. High demand on people because you have to learn how to do this, and maybe it shouldn't be done everywhere. The super difficult cases like super difficult AVMs, I don't think they should be treated everywhere. There should be special centers doing it, I think, whereas everyone should be able to do stroke and those kind of things. Right. So I think that, and also for robotics, I think I'm not sure that it will sort of be a super big thing locally, that you do everything now with a robot. I'm not sure that will happen. But let's say you could do a remote stroke treatment, for instance, like in the north of Sweden. That would be something. Yeah. That's where I really see this technique, this technology could bloom, actually. Right. So I think we will get there. Yeah. More technical stuff, better treatment for the benefit of the patients, and more controlled.
I'm curious to hear what your thought is. Obviously, Aruba has many of its own troubles in selections and everything. But do you think, because you brought up AVM treatment, do you think there's something that we learned from Aruba that is beneficial today?
I think everybody says Aruba is a shitty study. I can also see bad parts of that study. I can criticize it, definitely, and the criticism is valid in many ways. But I don't think that the results should be that nothing should be treated. No AVM should be treated at all. I don't think so. I think what it brought to us was a knowledge that, hey, this is actually quite dangerous. Because I saw before that, I saw patients being treated in a way that I was a little bit in doubt that this should have been done, and especially in this way. So I think what it brought, at least to me, was sort of a verification that, yes, this is dangerous. This is something that we need to do in a way that is safe for the patient. So it brought that knowledge and that awareness, and I think that's good. Yeah. But I don't think we should be dogmatic and say, okay, now nothing should be treated. No, I think we should, but we should do it in a better way. Yeah,
more thoughtful way.
Yeah.
All right, so 2 last questions, then I'll let you go. If we now turn attention to the training of future generations of interventionalists coming out today, what do you think we don't do enough today that we should do?
Yeah, I've been involved in the ECMINT. It's the ECMINT course. It's a cycle of 4 courses, and then it ends with the so-called diploma examination. And I was the chairman of the examination committee, so I organized the diploma examination and organized all the questions and so on and so forth. And I think people who took the course and did the full cycle, they all said we learned a lot. So theoretically, we have that course. ESNR has courses. WFNF-ITN has courses. So theoretically, yes, we have courses, and we need that. We also need a student working in an environment where there's debates, discussion, treatment, multi-specialist rounds, and just being in that environment, also good. So theoretically, yes. The problem is, I think, is the practical treatment, practical training. And I discussed that yesterday in my lecture. It's what's such a big difference coming from neurosurgery, where you were allowed to do anything almost in the beginning, and coming to neurointervention, where you were not allowed to do anything. And I think a mix is good, but for me, when I have fellows and residents, I have no problem letting other people do things if I think they are qualified to do it, step by step. And I'm there, I'm helping out, but they should do it. So I have, let's say I have a fellow who has been with us, or a resident even, for 6 months. He wants to put the flow diverter. Yeah, you do it. I'll be there, and we take it step by step. So I think the practical training needs to be more organized than it is today. And I think we should take advantage of simulators, of models, and those kind of things, and then stepwise help the younger generation more than we do, and let them do things. I think that's important.
Right. That's interesting. I've actually never thought about the difference in how hands-off or hands-on we are in different specialty, but coming from neurosurgery background, the same way, we just do it. We just do it, but perhaps there's a difference in other
Yes,
paths.
I mean, I have in my lecture, I have this, the first time I did the posterior fossa bleeding, my supervisor at the time, it was the middle of the night, and he wanted to go home. So he asked me, first thing, have you done this before? I said, no. Have you seen it? I said, no. Have you read about it? And I said, yes. And he said, good, okay. So he took a napkin and he draw, you make an incision here, you do this, put it on the wall, and he said, call me if there's a problem. Was this good? No, this is not good. On the other hand, I had to learn. I had to do it. Coming to neurointervention, I wasn't even allowed to touch the catheter for the first 3 months or something like that. I mean, no, this is so difficult, this is so difficult, you cannot do this, you cannot do that. So it was completely the opposite.
Right.
And to me, that's not good either.
Right.
So I think we should have a mix. You should be allowed to do it, but you should be allowed to do it with supervision, with help, and you should yourself use the simulator, try your best to be there, and also if there's a difficult treatment, you be there, you look, you see how people do it, you go to conferences, be ambitious, and then you learn. But I think the practical part needs to be more organized and better.
It's like now that I have to also kind of walk the junior through things, I'm seeing that it's a lot harder actually for the interventional stuff to fix problems. And so I think that translates into the tendency to be hands-on versus when it's an open surgery, you can easily reach and coagulate something versus if they have air embolism, I am hopeless, completely hopeless during training. So
it is a difference in attitude and in tradition. And I think that coming from neurosurgery, you're used to work a lot and you used to be there hands-on a lot. And I think it's also a lot about volume, actually. I mean, you should do as much as you can because this gives you a security, a good feeling, and so on. And also, if something goes wrong, that you don't panic. You can take a deep breath. You can ask a friend. You can think about, okay, can I save this situation and how should I do it? And I think their neurosurgeons are more used to that. And volume is important. Yeah.
Right. Gives you more tools in the toolbox, so to speak. Right?
Yeah.
So we're going to end on a more positive note. In the past months or years, what has been the highlight of our field, in your opinion, in terms of initiative, person, intervention, technologies?
Yeah, I think the development of stroke treatment, I think it's amazing that how it's developing and how it's getting better and how it's spread out, that's for sure. But I also think the recent development in endovascular treatments of difficult AVMs, difficult dural fistulas, but especially AVMs, where the technology has developed a lot and the techniques has developed a lot. I think that's, compared to when I started to do AVMs, I think it's a world of difference. And I think that's really impressive. So we saw, for instance, yesterday here, Vitor treated an AVM in a fantastic way that no one would have done some years ago. And I was very impressed, and I think this is really impressive. I think this pushes the field for these difficult diseases in a good way. So that's impressive, I think. And then if we can have the robotics for stroke in remote areas, that would be good also. I don't think we're there yet, but maybe in the future. Yeah.
Could really answer the question and the issue with limited resources in remote areas.
It would be good, and I think to me that's really the most interesting part of the robotic thing, if that could be done.
Well, Dr. Andersson, thank you so much for spending the time today.
My pleasure. Thanks for having me.